Care of the Aging Adult. This is the review for the final. Martha Olson from Iowa Lakes Community College. As we look at our main themes, we're looking at complications, early assessment, intervention, and what would the nurse do as follow-up. A lot of changes to the physical body as a result of the aging and complications that result from that, myths of aging, and then how do we manage the older adults, such as nurse manager qualities. Lab values are going to be important to know because when they're abnormal, we have to do something or report them so that something is done. Electrolytes, think of the diarrhea, think of the Lasix or furosemide that causes hypokalemia. The vulnerable older adult with any flu-like symptoms that can cause electrolyte imbalances, so review that. Hemoglobin and hematocrit, changes to that related to anemia, GI bleeds, blood loss. Most of the blood transfusions that I have administered have been to the older adult for one reason or another, and oftentimes their dyspnea, their lethargy is mistaken as old age instead of the anemia that they have. Kidney function because of the medication and the toxicity. Liver function tests usually done before medications are started to see where their baseline is, but need to keep following up with those. And again, the toxicity is a big issue. And then lipids and cholesterol also play key roles in prevention of strokes and heart attacks and MIs and all of that. When we look at the medications, what are the common meds that we think of that the elderly take? What are the high-risk medications? Digoxin, furosemide, potassium are just a few that come to mind, but we need to make sure that we know the toxicity, signs and symptoms, usually nausea, vomiting, halos, heart rate becomes very low or irregular. And then what are the medication routes if the patient is unable to swallow because they've had a stroke or other issues, like your cancer patient. We use a lot of topical medications, we use a lot of rectal medications in hospice. So kind of be thinking about the review of the different medication routes that we have. Looking at lab values, we know that with anemia and oftentimes a GI bleed, there are symptoms that show up for the older adult. Hemoglobin, remember, is 12 to 16 in that ballpark for the female and a little higher for the male. Blood transfusion, several test questions related to that when we think about administering blood, the consent, making sure that we get baseline vitals, that we have the correct type of tubing, that Y tubing, hang it with normal saline, make sure your IV is an 18 or a 20 with that, and then know your signs and symptoms of a reaction and what you would do. And the other big consideration with our older adult, if they have a little bit of congestive heart failure, is that fluid overload, and watching for that. Most of the time with older adults, the doctor will order 20 or 30 of Lasix between 2 units of blood just to take the fluid off, but to give them the good part of what they need in that blood transfusion. Potter and Perry, fluid volume status, make sure that you're reviewing what are the signs and symptoms of fluid volume overload, such as shortness of breath, which would be your priority, jugular vein distension, edema. When we look at fluid volume deficit, the tenting, the urine that is very dark, low urine output, blood pressure is a big one. Orthostatic hypotension goes along with fluid volume deficit, and that's a safety issue. And then again, with the blood transfusion, that fluid volume overload is a big consideration. Common diseases and disorders that you can anticipate to see for the older adult are listed here. We'll go through each one and kind of talk about the highlights of what you should be recalling as it relates to the older adult. The MI or myocardial infarction, the typical person might have chest pain. The atypical is going to come in and they're going to tell you that they have indigestion or they've had the flu for several days. When they're seen in the ER, think of what your priority interventions are. Get the telemetry on them, get an O2 sat and get oxygen on them. Get your IV started, so if you have to give rescue meds or the clot busters, that you're ready to go with that. Get a large IV in if possible. Again, airway, are they most comfortable sitting up? Do you remember from Introduction to Nursing, the orthopnea position. So we, think about not just giving the nitro. Make sure you have baseline vitals. Make sure you know where you're at with the oxygen status. Know the difference between telemetry and EKG. Which one would you do first if an older adult came in with chest pain? With our medications and lab values, Mona is one of the things we kind of think about. The morphine, you'd have to have your IV site in order to do that. It's not the first thing on our list, and remember, morphine vasodilates, so if your blood pressure is really low, it may lower it even more, and you may not want to give that. Your oxygen would be your priority, getting that started at 2 liters. After you get your O2 sat to see where you're at. The nitroglycerin will vasodilate, and so make sure that you know your protocol for your nitroglycerin, when it would be appropriate. Anything with a systolic 100 or less, I would hold off and make sure that you're conferring with your physician as to excuse me, giving that medication. And then many times your aspirin, because of the anticoagulant properties, might be a consideration. Lab values, remember your troponins, your myoglobins, your cardiac markers that help us distinguish, are they having an MI, have they had an MI, and where are we at in that process. The angina can be from blood loss and lack of hemoglobin because of the cardiac tissue not getting enough oxygen. So when you look at what lab values would be ordered, if somebody came in with chest pain, they might be anemic and having chest pain as a result of the anemia. With angina, again, our treatment would be rest. So if you were walking a patient in the hall and they started having chest pain, the first thing you would do is stop walking them and have them sit and rest, check vitals and O2 sat, get oxygen on them, and follow the protocol as needed. But many people, older adults, will have some angina, especially if they go out in the winter and try to scoop a little snow off their driveway, and they will oftentimes just go in the house and rest because they have that very often. Sometimes the pain is sensed very differently in the elderly, and so they may come in with atypical signs and symptoms for you. Thinking about the stroke, we think about, first of all, the prevention, that primary, looking at cholesterol and lipids and getting those lowered with your statin drugs. Diet, and that goes back to your nutrition content that you've had, lowering the saturated fat in the diet, and then lab values that go along with the stroke that we would want to look at to rule out that stroke. Your risk factors are listed there. We see many older adults that have had strokes as a result of untreated hypertension. The complications would be your third line because they've had the stroke, and we think about things like skin, falls, ADLs, aspiration, because of the results of the weakening to possibly one side or both sides from the stroke. After a stroke, oftentimes the aspiration causes a person to wind up having tube feedings. We also see tube feedings in your hospice patients or people that have Crohn's or colitis or GI disorders. So tube feedings can be for more than just the stroke patient. When we think about long-term versus short-term use, if it was just a couple of days, it may be an NG tube, but the more permanent placement is a PEG or a J tube. Your safer one obviously is the J tube because it's down further. It's got two valves that keep it from aspirating up into the lungs. It would be your lower esophageal and your pyloric sphincter. When we think about intermittent versus bolus in the hospital, where I've primarily worked, we do the intermittent. We have it on a kangaroo pump. We run it at the 40 or 50 milliliters per hour continuously because they tolerate it better. When you get to the long-term care and they have been getting the intermittent in the hospital, but now that we are transitioning them to a long-term care facility, the bolus, more like a meal, where when all the residents are down having their meal in the cafeteria, they will bolus the patient with maybe 300 milliliters of Jevity, head of the bed up, and it's just like a meal, but they're used to it at that point and they're able to tolerate it. Your signs and symptoms of dumping syndrome are change in vitals. They're very sweaty, they have diarrhea, they have cramping, their abdomen is very board-like, and they're not tolerating it well. In intro, we went through all of the things that a nurse would do if a patient is not tolerating their tube feedings. If that is something that you need to review, you would want to think about the importance of the head of the bed up so they don't aspirate, especially if it's a bolus feeding for about 45 minutes after the feeding. Also think about is the rate too fast, is longevity too strong, and they're not tolerating it, so we need to back them up to what they did tolerate before. They do still need water flushes in between to keep the tube from getting sticky and plugging, and also the water, just like you and I take a drink of water to keep our kidneys happy, we need that water throughout the day for them to stay hydrated. The tubing is changed every 24 hours because the longevity is sugar-based and it grows bacteria. And when we look at both of them, what is similar in both of them is they can affect their blood sugar, and many of our patients will have their blood sugar, especially if they're on the continuous one. We check their blood sugar 4 times a day, and that's not with meals. If they're on a continuous, it's every 6 hours. Typically in the hospital, it's 12-6, 12-6 that we're checking those blood sugars because it doesn't really correlate with a meal. Looking at our patient with long-term COPD or emphysema, oxygen administration is lower. We don't crank up their oxygen to get their O2 sats up to 94% or higher because they tolerate at a much lower rate that O2 sat. When we think about COPD, usually the rule of thumb is no more than 2 liters per nasal cannula because their drive to breathe is that CO2 level. The nasal cannula is typically used. It's very drying, and oftentimes patients will have bloody noses as a result, and so make sure that that oxygen is being humidified. If you move somebody up to a mask because they're a mouth breather, remember that a mask has to be run at a higher O2 level than the nasal cannula. Potter and Perry, I believe, talks about 6 liters is the minimum for oxygen with a mask. Your non-rebreather has that bag to fill, and that one is run at 15 liters per minute of oxygen. And then a CPAP is that used at night to help patients, and it's not just the older adults that we're seeing a lot of CPAPs. People that are obese, people that have sleep apnea, they wake up tired. It tends to be people with short, thick necks that often will need a CPAP machine, and those are not driven by oxygen, but they are driven by forced air. When we think about the delirium, dementia, and depression, it would be a good idea to kind of think about how are they alike, but more importantly, how are they different. On the board, the first day we did this activity when we looked at factors for confusion with the older adult, things such as hypokalemia or the electrolytes being off balanced. It can be a UTI, it can be dementia, but there are many other things that we try to rule out that can cause changes in the cognition for the older adult. As we think about the suicide with older adults, they are at risk, especially if they're widowed, newly widowed, if they have a lot of chronic health conditions, put them at higher risk. Some of the behaviors they may exhibit prior to a suicide attempt are very similar to what you learned in mental health. They give things away. They make comments about, their life not being worth living. They may be writing a suicide or a goodbye letter to somebody, which you would want to kind of pay attention to something like that as being serious. As we look at delirium, that is usually rapid onset. Causes of delirium can be things like a head injury, electrolyte imbalance. It can be a hypovolemia or hypotension can cause those types of symptoms. Dementia typically comes on slower, with the earliest symptoms being forgetfulness. They forget what they needed at the store to pay their bills, or where they went, or they drive around the block not sure of where they go. And then the depression signs and symptoms are what you learned in mental health. I will continue on with a second PowerPoint slide for you to help you with this review. Thank you.